Among self-referring urologists, the number of intensity-modulated radiation therapy procedures for prostate cancer rose from 80,000 to 366,000 from 2006 to 2010. And the article concluded that financial incentives for self-referring providers were likely a major factor driving the increase. Should we be surprised that men treated by self-referring urologists as compared with men treated by non-self-referring urologists are much more likely to undergo IMRT, especially given the costs of equipment and the high reimbursements? Isn't this just human nature?
Again, I must disclose that I sit on the board of the American Association of Clinical Urologists, and also I'm the chairman of the Society of University Urologists Health Policy. So I think with that disclosed, I probably can talk about this even as a pediatric urologist, since I've been involved with some of the reviews of this article and others. And maybe it provides, since I have no connection, a fairer opinion of kind of how we deal with this as an organization. As you know, the AUA has responded to this article, as has the American Association of Clinical Urologists and LUGPA, the Large Group Practice Association. There are some specific problems with the study that have been pointed out, I think, in many publications, including the AUA News, where this has been covered. There's been a subsequent article that was published in the Journal of Urology looking at specific use of new technologies that refutes a lot of the findings of this specific article. So my feeling is, as an academic urologist and pediatric urologist, I need good information. I need the data to find out whether any of these accusations are actually true. I'm not sure we completely have all of the data, but certainly that most recent article in the Journal of Urology would argue that both new technologies, for example, robotic surgery for prostatectomy along with IMRT, are both rising more rapidly than some of the previous treatments, because people are moving to those modern technologies as one of the factors with that increase.
Well, shouldn't the burden of proof rest with those doing the self-referrals?
Right.
In other words, they should have the burden of proof, because your gut instinct is that it's obviously going to make a difference.
Well, I think that's what we believe, I think, as our gut instinct. But again, I think you need to have the data to really support that. And the AUA has some guiding principles that they recommend for self-referral, and I think they're really good guiding principles. The first thing is you need to follow the state and federal regulations pertaining to the care. And in some instances, for example, standard radiology now, you have to actually provide information of alternative sites for your patients. But keeping that in mind, the most important thing is to have a complete discussion with the patient about what their disease process is and what the options are for their treatment. The other is to make sure that, at least if required, and optimally provide option for a second opinion. The other thing is to disclose that you have the facility yourself. And the final thing is there should be no problem with the patient going somewhere else and continuing to receive treatment at your facility. And those are good points, I think that really follow.
That is very good.